I'm a non-operative specialist, primary care sports medicine, and I see a lot of different types of athletes. And I was fortunate enough in my fellowship to work extensively with a lot of professional dancers in New York City, and that kind of piqued my interest in, first of all, recognizing the spectacular athletic abilities of these particular dancers, as well as the pathology that follows. I too have no financial disclosures. I do have to disclose that I have absolutely zero background in professional dancing, so please do not ask me to reproduce any of these maneuvers. All right, so just going over the overall epidemiology and prevalence, in line with the general population of other athletes, the most common injuries are the run-of-the-mill sprains, strains, and tendinopathy, which is when you have chronic wearing and tearing, thickening, and weakening of tendons that results in pain. These are most commonly seen in the lower extremity and back. Overuse injuries are exceptionally common in these athletes, as are stress injuries. Often these are due to some alignment issues, which for any of the physical therapists in the room, hopefully you have experience with treating these athletes and you can recognize these subtle changes that these athletes can make that may produce a huge yield in the reduction of these injuries. So I wanted to kind of dive in on some of the more nuanced and specific injuries that are seen in this patient cohort. I wanted to start by kind of lower down in the body and kind of moving our way up. So we're going to start with flexor hallucis longus, or FHL tendinitis. So for those that recall the anatomy of the ankle, Dr. Pasternak taught us about the bony anatomy. There's obviously a lot of soft tissue structures, ligaments, tendons that surround, and on the inside of the ankle, some of you may recall from your anatomy lessons the Tom, Dick, and very nervous Harry mnemonic to help remember the orientation of the tendons in the posteromedial aspect of the ankle. And one of those tendons, focusing in all the way toward the medial aspect, is this FHL tendon, the flexor hallucis longus, which helps to plantar flex the big toe, the great toe. And it's a very interesting muscle and tendon unit because it crosses over not only the ankle joint, but as well as that first MTP joint, which places an exceptional amount of tension and strain on that tendon. Now, this condition is very commonly seen with os trigonum, which I'll expand on in a bit. So it goes often hand in hand with this concept of the posterior ankle impingement. That's usually due to a presence of a abnormal or atypical bony abnormality, either a separate bone called an os trigonum, or this elongation in the back of the ankle called the Stata process. And this is commonly seen in female classical ballet dancers. We often see these on x-rays. Perhaps that's more likely because ballerinas are getting many more x-rays of their foot and ankle than many other people. But more commonly, especially in the 13 and up crowd, when these dancers start to go end point, which is when they go all the way up on their tippy toes, that's when these conditions become much more common. So what this leads to is if the ankle is relaxed and pointed, then there is well-preserved motion of the big toe. But when you dorsiflex the ankle and bring it up, it tightens that tendon and can lead to this functional hallux rigidus, or loss of motion at the big toe. And that will present as pain through multiple different sites along that tendon, sometimes behind the ankle, sometimes more distally further down on the tendon. So in terms of non-operative treatment options, as is common with most overuse injuries, there is often a component of underuse, right? We have to rest these injuries to allow for them to heal. It's a variable time. Then activity modifications and physical therapy make a big difference in these. So looking at things to avoid or modify the dancing to kind of avoid those steps that irritate the posterior ankle, and then in PT, kind of focusing on the mechanics of the foot and avoiding things like gripping in the ankle, which will lead to a shortening of that tendon, which will lead to a kind of lesser degree of this tendinitis of flaring up. Also very important to work on the intrinsic strengthening of those muscles within the foot, and then demonstrated here, this very simple stretching exercise going up against the leg of a chair, basically just trying to stretch that FHL tendon. Now, inevitably, some of these athletes will fail non-operative treatment, and there are good surgical options, and in particular an FHL tenosynovectomy where you kind of release that tendon, and then if there's an os trigonum present, often this will also be removed. Moving on up the body toward the hip, we're next focusing on coxosultans, which is otherwise known as snapping hip syndrome. This comes in several different varieties and flavors. It could be both painful and painless. Generally speaking, if it's painless, we don't really need to focus on it or address it, but it often can become painful. And then there's many different sites around the hip where you can experience this snapping. So there's internal snapping hip, which is usually caused by the iliopsoas muscle and tendon rubbing over the acetabulum, the socket of the hip. That is the type of snapping hip that is often felt by the dancer and the clinician. Then there's external snapping hip, which is on the outside of the hip, experienced when the IT band and the gluteus maximus tendon are snapping over the greater trochanter on the outside of the hip. That's the flavor of snapping hip that can be heard by the dancer and the clinician. And then there's more intra-articular pathologies that can cause an intra-articular variation of this, but that's less common, so we won't focus on that today. We're going to mainly focus on internal snapping hip, which is often accompanied by this very similar condition of what's known as iliopsoas syndrome. So what's seen is there's a pain or weakness in the anterior hip, and because the iliopsoas comes from the union of two different muscle groups, one that originates at the lumbar spine, you will often have concomitant low back pain accompanying that anterior hip pain. So this is often caused by repetitive hyperflexion and external rotation of the hip. And as I said, if it's painless, reassurance is all that's needed, and come back if it's painful. If it is painful, again, we start with some activity modifications, things that are specific to dancers and in particular ballerinas, right? We ask them to kind of lower their extension so they're not pushing themselves to that terminal range of motion where they're becoming painful. We ask them to bring in their turnout. The concept of turnout in a dancer is when you externally rotate your hip, which results in the foot turning out. So we kind of narrow that and modify and bring that inward. And then jeté is a jump. Many ballerina terms are French, so we just ask them to kind of modify and avoid things like grand jetés demonstrated here, where they are kind of, as you can see, maximally extending the hip. PT, again, paramount. The tried and true method that I have found to be most effective for iliopsoas syndrome is this kind of trifecta of treatment that involves stretching and strengthening the iliopsoas, pelvic mobilization, and then anti-lordotics, so working on reducing that exaggerated lordotic curvature of the lumbar spine that results because of this tightness of the iliopsoas. For those that fail PT, usually there is an option to try an ultrasound-guided injection, usually targeting the psoas tendon and bursa, and that can alleviate some inflammation locally that might reduce that friction and rubbing that's causing that painful snapping. And then again, if they fail all other non-operative treatment options, then there is a surgical option to kind of release that tendon and reduce the pain that way. Lastly, kind of moving on to our last pathology. So many lumbar spine injuries seen in dancers. It's a wide range of pathology that includes strains, radiculopathy like sciatica, sacroiliac joint dysfunction, and then what we're focusing on today, which is spondylolysis, which is a stress fracture in the low back. So it was ingrained in my mind during fellowship that all low back pain in dancers is a spondylolysis until proven otherwise, because it's one of those can't miss diagnoses. So that's something that's going to present. It's not going to be an acute injury, most likely. It's going to be an overuse chronic injury, and it's going to bother dancers when they are extending their lumbar spine or leaning backward. It most often involves a particular portion of the lumbar spine called the pars interarticularis, but we can see stress fractures and more subtly stress reactions in various other aspects of the posterior elements of the spine as well. So some other risk factors are for the male dancers that are engaging in a lot of heavy lifting. That also involves the core and the lumbar spine. And then when there's a raked stage, which is when the stage is kind of slanted forward slightly to increase the viewability for the audience, that can also lead to this increased risk of these overuse injuries. So in terms of treatment, there's actually a lot of emerging evidence that physical therapy can be initiated right away, and that can be very helpful for these dancers. And for the most part, that is what I apply in my practice. I will say that I take it on a case-by-case basis because often these are teenagers, and as many of you know who treat teenagers, if you give them an inch, they'll take a mile. So it's a stress fracture, right? So I think a key component is rest. So it varies a little bit. Sometimes I'll have them start on PT right away. Sometimes I'll just tell them we need to shut things down completely for 3-4 weeks and then initiate physical therapy once that pain is reduced and I've gotten them a little bit more compliant and bought in on this lengthy recovery process. This is a always tough conversation to have. These athletes are extremely emotionally invested in their sport, obviously, and this is usually a 3-month timetable, which is always a big emotional blow to these dancers. So to get them to buy in and appreciate the importance of avoiding the movements that are going to exaggerate things like lumbar extension is extremely important for their healing. PT comes in, core strengthening, correcting those postural malalignments, and if there's anything that we're picking up on, things like sway back or flat back, things to kind of work on re-implementing the natural design of the spine can be very helpful in this recovery as well as preventing it from coming back in the future. Most often, if done properly, these types of athletes do not end up needing surgery. About 10% or fewer sometimes do. Usually I'm trying to push that off as long as possible. I give them that 3-month time frame. If we're getting in that 4, 5, or 6-month period and they're still having pain, they're unable to really do the physical therapy maneuvers, that's where potentially we're getting some further imaging involved, and then potentially we're referring to neurosurgery or ortho spine for some surgical management. And that's all I have for you. Thank you.